We have a 40-year-old male, history of psoriatic arthritis, for which he received a lot of immunosuppression, including methotrexate, and he is an US resident, and then he was evaluated there, and the CT scan shows multiple pulmonary nodules, 4 millimeters to 5 millimeters in size, and also mediastinal lymphadenopathy. So looks more like an infective etiology. We perform a quick diagnostic bronchoscopy using the 530T scope from Fujifilm, and then see if there are any endobronchial abnormalities. Following that, we will demonstrate the mediastinal lymph node cryobiopsy using the Fuji 530 US. So I will just run through a quick diagnostic bronchoscope. The patient is on a supraglottic device, general anesthesia, and then I run a bronchoscope quickly to see if there is any endobronchial problems. The upper lobe on the right, and the tracheobronchial tree relatively looks normal. So now we shift on to the endobronchial ultrasound. Here quickly. Now we move on to demonstration of mediastinal lymph node cryobiopsy. Just change to the EB530 US scope. Jelly in this one. Stop. Now we quickly shift to the EB scope. I connected the EB530 US scope and then perform mediastinal lymph node cryobiopsy. The advantage of using the 530 US scope is that it has got a very high definition bronchoscopic image, unlike the other EB scopes, wherein you don't have to really do a diagnostic bronchoscopy before performing EBUS as a routine. As you can see, the image matches with the conventional white light bronchoscopy. And the idea here is based on the imaging, we have station 7, which is the node of our interest, but also we will quickly screen the station 4R here. Now you can see this is the superior vena cava, and then as you push the scope, you can very clearly identify the azygos draining into the superior vena cava. So you can appreciate the quality of the ultrasound when you connect the aerator to the 530 US scope, and then look the lesion of our interest. So this is the station 7, and you can see a large lymph node, not truly round, maybe you can call it round, yeah, heterogeneous, and no areas of necrosis as such I can see here. Well defined borders for the lymph node, more than 1 centimeter in size, and then we will put the Doppler to see the vascularity of the lymph node, not very vascular. So this is the large image of the lymph node. I am at the station 7 now, and then we will try and demonstrate the technique of mediastinal lymph node cryobiopsy, in this case using the electrosurgical knife cut, and then through that we will pass the cryoprobe. So now Dr. Preeti will give me the knife. And then we move on to the so you can see the sheath of the knife here. Now once the sheath of the knife comes in and the ultrasound, the other advantage using this scope is, usually when we pass instruments through the bronchoscope, EBUS bronchoscope, we usually come in neutral position. But as seen in this case, you can just keep the node of your interest in position, keep the scope flexed, still you can pass these small instruments through the working channel of the bronchoscope. That is an added advantage, and there is no scope damage when you do that. Now I will ask Dr. Preeti to just get the needle out of the sheath. So she gently pulls the needle out of the sheath, and then I try to pierce the needle under vision, as you can see here, into the mucosa and then shift into the ultrasound mode. So now you can appreciate the entry point of my needle also on the ultrasound very clearly, and then this is done all under direct vision in real time. And then I am using an RB Vio 3 processor to create the cut here using the endocut I mode. The signal is a little, yeah. I make one cut and then extend the incision of that cut by doing one more cutting. So now I will ask the assistant doctor to pull the needle into the sheath. Bronchoscope image please. And then you can clearly appreciate the area of puncture using the electrosurgical knife here. And then now I ask the assistant to give the cryoprobe. She is already standing with the cryoprobe, 1.1 millimeter cryoprobe from RB, and then under direct vision I try to get the cryoprobe and then pass the cryoprobe into the space. Can we shift on to the ultrasound? Yes. Now you can very clearly appreciate the passage of cryoprobe into the lymph node, and then I can just make a small swift motion to understand the tip and the position of the cryoprobe. See how quickly I am able to enter into the lymph node and then push my cryoprobe and then get sampling with definite tissue using the cryoprobe, because we know whenever we use cryoprobes in the mediastinum, you are assured of the tissue that comes out of the cryoprobe. So I once again just push the cryoprobe inside, outside, and then put the Doppler to see there are not major vessels around the cryoprobe, and then make a quick freezing. So the initial freezing time will be 3 seconds, and for the consecutive passes we will freeze for 5-6 seconds. So I will just activate the cryoprobe now. And then we take the initial pass for a cryo imprint crush cytology. So you can just take this whole sample. We allow the sample to thaw outside and then rub the sample. I can see very clear blackish material that is representative of the lymph node. So the differentials of this patient is more towards infection rather than malignancy as per the clinical data that is available for us. And I think the available literature also now favors more advantage of cryobiopsies in these kind of pathologies rather than malignancies. So I quickly run with my scope to see if the puncture site and if there is any bleeding, and you can see there is no even the small bleed that usually comes through the needle passes, demonstrating the safety of this procedure. So one should not consider bleeding as a real important risk factor when you do mediastinal lymph node cryobiopsy, as demonstrated in this case. And then we will quickly go on with the further passes of the cryoprobe. So I would like to show you the passage. So when you have the first pass and a small smudge around that area, you don't really have to worry about spending time on identifying that hole. You just follow the ultrasound image. Now you can see, just see how smooth the puncture of the electrocautery knife is and how smoothly the cryoprobe is going. And for those who think that cryobiopsy cannot be done in different areas of the lymph node, it's not true. you can just do your flexion extension and then also insert and change the direction of your cryoprobe, as I am doing in this case. Now I am trying to move my scope a little farther away and then trying to freeze the scope in a different area than the first biopsy. So now this a quick Doppler before every procedure, a very quick one, yeah, no vessels around it, done. And then freeze. As I told you, with the consecutive passes you can increase the sample size. That is one advantage over the needles. Needles and forceps, they always have a fixed volume of tissue whenever you go into the lymph node. So here I will demonstrate by freezing for 6 seconds. Now you can increase the sample size that comes out through the, see how good the tissue almost looks like a sample from the transbronchial cryobiopsy for the ILD patients. Yeah, and then we will make the rub once again. And then these samples will go on for the tele-rows. You can, yeah. So now I will not move my cryoprobe outside the bronchoscope. I will keep the cryoprobe inside and then quickly finish the further passes. Keep clean. Again, you can very clearly appreciate here, even with a 6 seconds freezing, I did probably a 6-second freezing on the cryo machine. Still you can see there is no increased bleeding or any complication. Then shift on to the ultrasound. The cryoprobe is still in the ebuscope, so this time we don't have to spend more time. Just focus on the area where you have made the puncture and then try to get the cryoprobe. How smooth the entry will be, you can very clearly appreciate the echogenicity of the needle inside the lymph node. So I go a little farther, push my probe there, again 5 seconds of freezing and then sample. I think the use of Ariat definitely improves the ultrasound quality in this EBUS imaging. What's your opinion?
Yes, sir.
So where do you find the difference?
The quality of the ultrasound is better, the contrast is better.
Yes. So I think it's a great addition to the current available EBUS system. And then you see, I will move the cryoprobe inside and outside. Freezing for another 5 seconds. Now we have completed 4 samples. And then we will go for the 5th sample. Though, because this is the diagnosis in doubt is more of benign, we also take 2 final samples for culture to check the microbiology, mostly of the tuberculosis and fungal infections. So because this patient is from is a US resident, here we have to have other diseases other than TB like histoplasma, which because they are little endemic in those areas where he is living in. So I will just quickly run through small NS. Just clear the spot. The last 2 samples will go for microbiology for culture and expert for the tuberculosis. Again, see how quick and then how smooth the transition from the mucosa of entry to the lymph node. And the last pass. I think the visibility of the cryoprobe is too clear when we use the Arietta 750. No? Doppler, quick Doppler, all the time, quick Doppler, every pass, close. See the amount of tissue that comes when you do the freezing in the consecutive sampling. This is more than any other sampling in the mediastinum that can do the mediastinal sampling, especially when you use endoscopy techniques. And we can also visually inspect the size of the samples on a glass slide, amount of samples that we got in this, and Dr. Preeti will show you the morphology of the samples that acquired through the lymph node on a slide, and we will wait for the answer from the histopathology for the cytologist for giving a rapid review of what they are seeing. I think
these are the 6 samples we have obtained. We can appreciate the size of the tissue. It is almost like a transbronchial lung biopsy, and this is the amount of tissue got using the cryoprobe, which is more than the tissue that we get using any modality.
What do you think of sampling in lymphoma using this?
The tissue is sufficient for lymphoma and subtyping also. Even in malignancy, I think the tissue will be sufficient for immunohistochemistry and also the NGS panel.
Yeah, so this is clearly demonstrates the advantage of cryobiopsy over other sampling techniques like the forceps and needle, where the tissue that we obtain is already fixed volume. But here you can increase the volume based on this sampling also. You can see based on the different freezing times that we use, we have different size of the tissue, which is not possible with the other sampling techniques. So with that, we will go on to the rapid on-site slide evaluation. Quickly moving on to the rapid on-site evaluation. Now we have the slides that are available. You can see on the background of lymphocytes a well-formed epithelioid granuloma with some scanty necrosis here and there, and demonstrating a clear granuloma more favoring tuberculosis etiology. Anyways, we have more samples that we have collected for tissue culture also. We will wait for the tissue culture, but we are able to demonstrate during the procedure that this is a case of granulomatous pathology using the mediastinal cryobiopsy 1.1 cryoprobe from RB, and the demonstration of the procedure using the Fujifilm integrated with the Arietta 750 processor, making the imaging much clearer than before.